Good morning, good afternoon, and good evening, everyone. It's great to have so many on the line today. Again, my name is Anjali Achrekar, and I'm so privileged to serve as the acting U.S. Global AIDS Coordinator as we await our nominee, Dr. Kengasong, to be confirmed. I'd like to warmly welcome you to the official closing of PEPFAR's country and regional operational planning process for 2022. Together, we gather at the conclusion of 4 intense weeks of country and regional operational planning that we've all engaged in as committed partners in the global HIV fight. Across the whole of US government, from countries and headquarters, partner governments, all sectors within the governments, multilateral partners, private sector partners, local and global civil society, and other international and local partners. We've come together through these intense weeks of planning to discuss, to debate, to interrogate data, to raise issues, to resolve issues, to share solutions, to use data for decision-making. In summary, to participate in transparent, data-driven joint planning where everyone's voice matters. With one focus, to ensure that every US dollar that we're privileged to invest through PEPFAR is yielding or will yield the greatest possible impact and results for the people that we serve. And I want to thank you for all of your contributions to this effort. We've gone through so much in the past many months, whether it's 2 years or over 2 years of COVID, civil unrest in some countries, environmental crises in others, or the ultimate devastation of war that our dear Ukrainian brothers and sisters continue to fight through now over a month later. Through it all, the power of people, the power of partnership, the power and resilience of PEPFAR is ever present and the foundation that brings hope and light to so many, even in the midst of such challenges. Today, at this closing session, we'll hear from a keynote speaker, a friend, Dr. Ahmed Omar, who's the Deputy Director of the Africa Centers of Disease Control and Prevention. We'll then hear from Iram Zaidi from ASCAC, who will provide highlights reflecting all of examples of solutions and innovations in program implementation through the planning process. And then we'll hear from agency leaders. So without further ado, if we could move to the next slide, please. And I know, and actually we'll come back. Oh, fantastic. Dr. Ahmed, welcome. Welcome.
Thanks, Anjali. Some connection challenges
No
here,
problem.
but I'm here.
No problem. You're most welcome. And we're so pleased you're able to join us, Dr. Ahmed Omar, the Deputy Director of Africa CDC. He will provide keynote remarks and kick us off for this conversation. Dr. Ahmed, the floor is yours.
No, thank you. Thank you very much, Anjali, and good morning, good afternoon, good evening. I know people are joining from different timelines. I really bring very warm greetings from Addis Ababa, the seat of the Africa Union here in Ethiopia. I also bring very warm greetings from the Africa CDC itself. It's an honor, Anjali, to be invited to this closing session of the very important work of country operational planning that the PEPFAR team is doing with your various partners. So thank you very much for inviting me to participate, and I have no doubt that the planning exercise that you've been through has been a success. And at Africa CDC, we are really looking forward to expanding our partnership with PEPFAR and indeed all those who are on this call today to safeguard Africa's health. Africa CDC, as you know, was born out of a crisis. During the Ebola outbreak in West Africa in 2014, 2016, African heads of state and government decided that it was time for the continent to have its own agency responsible for health security. That vision not only grew, it's germinated very well into what today you see as Africa CDC. And in fact, in my view, it is one of the most significant investments in public health in Africa for generations. The agency was then launched on the 31st of January of 2017, and it went straight to work. When Africa CDC was launched, then there was I think it was the 9th outbreak of Ebola in DRC, and the Africa CDC was called upon to immediately go and provide support. Of course, the pandemic now has become a very big test and indeed a very big opportunity for us as Africa CDC to realize the vision of setting up this agency so that we can realize all the aspirations that our heads of states had on a health security agency on the continent. Very much like Africa CDC, PEPFAR is also a vision of your head of state whose implementation has been a game changer in addressing HIV challenges on the continent, particularly here in Africa. PEPFAR has over the years established a very robust network of partners, both state and non-state actors, and in the process has strengthened the health system across our continent. This is a vision, the vision of strengthening the health system on the continent is a vision that our two organizations share. And therefore, that vision provides an opportunity for us to expand our partnership to the benefit of the continent and indeed public health in general across the globe. The COVID-19 pandemic has presented Africa CDC and the continent with some key lessons. And today, I would like to share with you a few that will be relevant for the conversation that we are having around work with PEPFAR. The first lesson is political leadership and solidarity. Our heads of state, in fact, today as I speak, our heads of state on the continent have met at least 18 times to discuss nothing but COVID-19, what is happening, what the strategies Africa CDC are proposing, them discussing how the continent can be more engaged. So at least 18 times that our heads of states have met. This regular meeting during the pandemic has provided the continent with visibility of what needs to be done, and decisions have been made so that concrete things have also been done during this time. And all these meetings were being called under the auspices of the Africa Union Assembly of Heads of State. Each time that our heads of state have met, they have invited Africa CDC to brief them on the evolving nature of the pandemic. And during these sessions, we share our technical advice and also propose some strategies and approaches that we can be able to use to slow down COVID-19 on the continent. This solidarity at the highest levels in Africa resulted in the continent working together as one, addressing challenges that included, in the beginning, there was issues around access to diagnostics and PPEs, and more lately, access to vaccines. This working together has also ensured that countries have aligned their plans and responses at country level, and all these have been done around proven public health measures. So Africa has really been using a lot of evidence in as far as taking forward action against the pandemic is concerned. This solidarity and leadership has saved many lives in Africa. And as Africa CDC, we really feel privileged and honored to have been part of this historic moment when our heads of states are guiding very directly a response to COVID-19. The second lesson that we have learned is that having effective coordination at both the political and the technical levels is invaluable, especially when you have a fast-moving health emergency like COVID-19. As Africa CDC, we established the Africa Task Force on Coronavirus Outbreak, we call it AFCO in short, in February of 2020, soon before the first case was actually identified on the continent. We also established ministerial coordination platforms through the Africa Union mechanism. And these were for health ministers, for finance ministers, and for transport ministers, because these three were the key policy areas that needed intervention during the pandemic. These ministerial forums have been instrumental in getting the continent to plan and act collectively during the lockdowns and indeed during vaccines acquisition. The AFCO, the task force that we established, is composed of directors of national CDCs or national public health institutes who lead various technical working groups in formulating interventions that are best for the continent. These interventions have gone ahead to receive approval from our heads of states when we brief them and we bring forward what the thinking is. And all these interventions have actually received approval from the heads of states, and Africa CDC has been tasked to coordinate implementation in Africa. This is a mandate that we take very seriously, and all our resources, be it human, financial, technical, political capital, all our resources have been deployed to meet this growing need in terms of expectation from our member states at their very highest levels of leadership. Thirdly, Africa has few public health assets that we can call upon at short notice during a health emergency. What we've learned during this pandemic is that when we network these public health assets to serve either a region or eventually the whole continent, we find that it immediately opens up Africa to be more self-reliant. We have many more public health assets to draw on, and each country doesn't have to establish its own public health asset. For example, advanced labs that need to perform pathogen genomics work on the continent are very few. But today, we have networked them, and we have built capacity of all these networked laboratories and provided them with the much needed equipment and consumables to enable African countries to access sequencing services through an efficient sample transfer system. We have few labs that do sequencing, but all the countries on the continent can be able to have their samples sequenced within the shortest possible time. In fact, we are very proud of the fact that African scientists have led in this area of work globally. And during the pandemic, many of the variants that we have seen were first characterized here on the continent, and our scientists and governments went ahead and publicly shared the work of these, the work of COVID-19 variants. Although this came with its own risks, with sometimes Africa being labeled as hotspots and providing us with challenges in terms of travel. But for us, science won here in Africa, and we have encouraged our scientists to continue their work and make them publicly available so that we know what is happening here on the continent. The networking of these public health assets, including professionals, experts, advanced labs, research institutions, training facilities, and others, is a very key strategy for us at Africa CDC. We call it RISLNet, the Regional Surveillance and Laboratory Networks, where we bring together all these assets under one coordination so that we can be able to use it for the whole continent at the same time. This networking works, and Africa CDCs continues to expand the networks and their capabilities on the continent. Finally, we have learned that Africa has some infrastructure for public health, and harnessing all these assets has made it faster for us to respond to COVID-19. During the initial stages of the pandemic, when testing for COVID-19 was a challenge on the continent, PCR machines that had been installed for HIV work were we encouraged countries to expand their repertoire so that they included testing for COVID-19 as we increase the capacity at country level for testing. So infrastructure that was already there was then used for the pandemic. During the current vaccination rollout on the continent, we have seen that the Africa Union Assembly, our heads of states, have called upon member states to facilitate the achievement of the 70% target that we have set for ourselves. Now, to make this a reality, many countries, good examples include Uganda and Zambia, have utilized the public health assets for HIV that PEPFAR had developed over time to be able to rapidly expand COVID-19 vaccination, and the results have been really, really good. And these are just a few examples of how we can be able to leverage on what we already have to strengthen our health systems. And these examples are worth emulating so that each country can be able to see the opportunity of quickly deploying its public health assets where there is a disease threat of any kind. Infrastructure and capacity that PEPFAR has built over time and also will continue to build as you expand your work on the continent are extremely valuable when the continent is faced with any other disease threat, even post a pandemic. It also confirms that all disease threats, all of them, should be approached with a health security lens, whether it is HIV, malaria, TB, or any other new pathogens that may be able to come. Let me finish my intervention by reminding all of us that Africa has seen significant success with the pandemic because we believed in and did big, bold things. We didn't wait to do things in a small way. We went out and did big things in a very bold way. This we did to achieve the change in public health response that you have seen Africa benefit from during this pandemic. We have initiated over 12 different initiatives that are linked to the COVID-19 pandemic, and we are implementing all of them as we speak. We therefore are persuaded that if the rest of the world also approached all disease threats as health security threats and worked together, mobilizing its own internal and external resources, then we can achieve much, much more in public health. I therefore invite PEPFAR, indeed the whole of the US government, and all your partners and stakeholders that are represented here today to do the same. Let's approach disease threats from the health security lens. I also would like to invite you to join us as Africa CDC and the Africa Union as we implement Africa's new public health order, whose pillars are 4: strengthening African institutions that are dealing with public health emergencies; 2, strengthening public health workforce here on the continent; 3, securing our supply chain through local manufacturing of emergency health products; and 4, building partnerships that are action-oriented and are based on the priorities of Africa, and starting with domestic resource mobilization, so that the countries and the partners who are here on the continent come through and ensure that local resources are being used before we can be able to call upon friends of Africa to join us in securing any disease threat that may come our way. Africa CDC and the Africa Union are open to partner with all of you and with the same goal of safeguarding Africa's health. I thank you for your attention, and it is a pleasure to be here with you today. Back to you, Anjali.
Thank you so much, Ahmed. Thank you so much for your leadership. Thank you for your reflections, really emphasizing the power of partnership, of networked partnership, of networked public health assets, and what is possible if we have big, bold vision and act on that big, bold vision together. Disease threats through the lens of health security. Thank you so much, and we look forward to continuing to collaborate together. Next, we'll have Iram Zaidi, our Deputy Coordinator for PRIME at the Office of the Global AIDS Coordinator, highlight key program areas that we've learned from all of you as we've gone through the planning process. So Iram, over to you.
Thank you, Anjali, and I will keep my video on for just a second just to say hello. I'm very pleased to be able to do this review here from Nairobi. So good afternoon, everybody. Good evening and good morning. It's great to say good morning and not good afternoon and good evening. I'm going to turn my video off to make sure we can hear me well. So thank you all for a very robust planning process over these past 4 weeks and really looking into where we've seen solutions, the adaptations, and the innovations to take to scale. Dr. Omu already touched on many of the foundational pieces that we've been implementing in PEPFAR over the past 19 years. And I think the foundational pieces have really helped us now to address the specific areas by population, by site, by actual technical tools. And I'm going to highlight some of those select ones from across the countries given the time today. So I'll just say next slide. And we can go to the next slide, please. From the HIV clinical services perspective, Zambia, who has very strong results coming out from their FIA, very exciting to see those. They've been using their individual level information and triangulating this data integration and triangulation to see where do they have differences in interruption and treatment. And they see, and it's not surprising, unfortunately, but that interruption in treatment happens among our younger populations, among our youngest populations, 1 to 4. And as they dug into that information even more specifically, they saw that those who were on 6 months of MMD, and again, they're able to triangulate their logistic pharmacy data with their individual client level data. They see that 6-month MMD is a very important intervention to keep people individually on ART and virally suppressed. However, only 50% of 15 to 24-year-olds are on 6-month MD. These are solutions now that they're addressing and moving forward in COP21 and in COP22. Next slide, please. Turning to Zimbabwe. Zimbabwe is very, and I'll touch on this in just a minute, key information really coming out of their clinical monitoring information, where interruption in treatment is IIT, where there's very important information about what is happening at the site level, what services are available. We hear about the policy implementation, but the actualities and the availability of that is different by population, by site, by district. And in Zimbabwe, they really looked at the pieces around ensuring quality clinical services with viral load results for patients. They've been scaling up viral load testing. They've now been focusing and looking at where they have specific gaps in returning results back to the sites and in specimen transport, and getting down to these very functional pieces within the laboratory system to ensure that patients are receiving effective treatment regimens, has improved then the turnaround time for results back to the individual and availability of viral load for the client as well. Next slide, please. And in Mozambique, really amazing work across the Mozambique program. In the past 2 years, despite COVID, they have continued to scale services and looking now at information by not only age and sex, but site, and ensuring that their quality and site level standards and by population. In COP22, they've started this work in COP21 and having the male focused packages in each of the clinics where males are likely to come, and they're scaling those in COP22, looking at these very specific solutions by population. Next slide, please. And I touched on this before, next slide. Looking at CLM was really instructive for Team Zimbabwe. They found that there were very specific pieces in the feedback from community-led monitoring that went directly into their service and quality improvement. Looking at the retention, looking at drug shortages across facilities, HIV drug literacy, viral load information, availability of human resources and testing, all serviced into their program and into their COP, not only for COP21 implementation, but then addressing those in foundational adjustments in COP22. Next slide, please. And here, a very specific outcome in relation to community-led monitoring, where we could see all this was an important piece that we addressed of user fees in COP19, that despite the circulars for user fees being abolished, there were sites that were still charging these user fees. They were able to work with governments at all levels to address these, and now have a routine process to bring these and address these with government as these issues are coming on board. So really amazing work in real time changes coming out of community-led monitoring. Next slide. I'll cover some highlights for pediatrics, OVC, and PMTCT. Again, there is amazing work happening across the program, and looking then at these specific highlights, it doesn't mean to ignore anybody, but here in Malawi, this program adaptation that we made, and really focusing, and it's not a new piece, but having OVC programming working in support for pediatric HIV treatment has been really important. And we're now seeing examples that are being taken to scale in districts and clinical facilities where that partnership is actually working to serve the pediatric client and the family of the pediatric client. Here in Malawi, we see with this work that OVCs are actually, this is facilitating the transition to pediatric DTG, and it's facilitating viral load suppression and a healthier life for HIV positive individuals. Next slide, please. And further in Malawi, we see the early childhood models that they're going to be scaling in COP22, looking at mother-baby pairs, adherence and ART during pregnancy and then throughout breastfeeding. We know that's a very vulnerable time. Ensuring that infants and the whole family is receiving PCR and EID results on an on-time manner so there can be appropriate action taken. And then ensuring that there is daily ART for the mother and prophylaxis for the baby, so that we can get that final negative HIV outcome. And working together in the education and the strengthening of the mother and the household helps with the retention and early education. Next slide, please. Turning to Mozambique, and I know there's another example from Mozambique, but they've really been doing a stellar job, looking in the most granular and detailed way by site, by population, and looking at where, as they've been implementing their Ajuda packages, do they see differences in screening for pregnant women, and then post ANC1 for implementation of PrEP and retesting to prevent that mother to child transmission, even post ANC1. Next slide, please. And finally here with Zambia and the pediatric ART optimization. We know it's taken a while for the pediatric regimens to follow the adult, but finally we see that here in Zambia, they were able to get to just over a short period better viral load suppression by changing to more effective HIV ART regimens that are better for the individual, particularly for children, and having better outcomes. Next slide, please. I'll turn now to PrEP and prevention for adolescent girls and adolescent girls and young women. Next slide, please. Thank you. I just want to pause here for a moment. We've talked about the youth and demographic shifts that have been occurring across our countries, and DREAMS has been a critical program implementation to address this. Reducing the incidence is not sufficient when we have a growing population of under 15 and under 30-year-olds across our countries in sub-Saharan Africa. In Eastern Africa, in Uganda, Tanzania, In Kenya, where I am today, over the past 30 years, there's been a tripling. Yes, a tripling of this population, which is amazing. That speaks to longer life expectancy, better outcomes at a pediatric level. And as we see these changes, looking at where these population changes are occurring by percentage for adolescent girls and young women, and by total count. And this, in integrating this information with HIV disease burden and prevention, is critical. And I know many of the country teams have planned in this year to really confront this head on. Next slide, please. In South Africa, they're furthering their integration with OVC, DREAMS, school health, and bringing all of this together for children living with HIV in a way that supports prevention services in school, OVC services for HIV testing in children of index clients, and then looking at where there are children of key populations and incorporating them in positive and best practices. And then finally in DREAMS, and bringing and triangulating all of this. As we need to maintain epidemic control and sustain HIV impact, really breaking down these silos and working across services by population. And you can see some of that innovative work starting in South Africa. Next slide, please. Here in Namibia, looking at PrEP expansion for adolescent girls and young women. Overall, and not just here in Namibia, but overall in COP22, and I know we're not totally finished with COP22, there has been an increase of over 36% of newly initiating individuals on PrEP. We're learning how to address continuity on PrEP, making sure it's appropriate and feasible for each individual client, each population, and serving in the ways that are effective for their own prevention and lifestyles. And here in Namibia, really looking at those deep places of education for demand creation, having the DREAMS ambassadors promote PrEP and lead the PrEP clubs, that peer-to-peer work. There's no substitution for that. And then working closely with ministries of health on ensuring that the pill bottle is acceptable and people are willing to walk around with those, that there is appropriate changes with the safety and starting and stopping. So policy pieces, as well as really operational pieces to make sure that individuals can access PrEP services as they need. Next slide, please. And just want to reiterate that we in COP22 and even now that PrEP is offered to all highly vulnerable adolescent girls and young women, that it's not just offered to female sex workers or this population in serodiscordant couples, and it's not based on a screening tool, because adolescent girls and young women may not be comfortable disclosing their own individual risk. And so just to reiterate, we would not withhold effective HIV treatment from individuals, although we have in the past, but we should learn from those and ensure that we offer PrEP to all. Next slide. I'm really excited about the program in Uganda. They have continued to scale key population services in a very efficient manner. From COP19 to COP22, they've expanded from 39 to 65 districts and continue to reach more and more key populations. And on the right, you can see how they've been planning at that district level. Next slide, please. Here, they were able to look at what is happening with PrEP demand. Who is it being offered to? Who is accepting it? And what are the specific pieces around making sure those who need PrEP are able to access and stay on PrEP. So looking at same-day PrEP initiation in hotspots, CQI to improve that initiation for eligible clients, and really looking at that granular site and individual level to understand how PrEP is being implemented and scaled. Next slide, please. And this one is just really reassuring. They're working on many structural pieces in Uganda with ministries of health, including this piece that's so critical, and making sure their policies and laws for equitable access to HIV services, and accrediting having the Ministry of Health accredit the drop-in centers so that they can be an HIV treatment platform. Fantastic work. Next slide, please. On this slide, I wanted to talk a little bit about how in Eswatini, they're using findings from recency to indicate, are we testing in the right ways with the right populations and the right modalities so that we can address specific populations where incidents or new infections are being identified. Through their work and implementation of recency, they find the 15 to 29-year-old females and the 20 to 34-year-old males to be where those patterns of new infections are the highest, and through their implementation of recency. And what they're finding is that even through the implementation of HIV testing services, they see nearly 47% of those who are diagnosed in the year are actually not only a repeat positive, but have been already on ART. And so if you think about the point I was making about the youth bulge and the demographic shifts, looking at our new infections, looking at our HIV case finding programs, our clinical services, our prevention, are we adapting, continuously adapting in the geographies and in the population? So looking at this information in a way that helps us understand if our program implementation is in the right places. Next slide, please. Really exciting to see scaling of HIV self-testing in Trinidad. Trinidad's program, over 90 across the country. Really heartening to see how they've been adaptive and innovative over the past few years. And their work in self-testing starting from last year and looking at that educational piece at the clinical site, at the community site, amending government policies, the communication across the program, including the HIV helpline so people can understand where they can get self-testing, and then monitoring that. And not only through the programmatic lens, but then also ensuring that the supply chain is there through the Ministry of Health Services. Really exciting to see, HIV self-testing by specific population and really providing those in the variety of ways across the country in Trinidad. Next slide, please. And then none of this could be without human resources. And in Zimbabwe, they I think was, from what I can see, one of the teams that really maximized the use of this information and analyzing the gaps in service delivery by lab, by clinic, and by community, so that these precious resources can be targeted where they're needed the most. They're finding, which is so important, and as we think about and what Dr. Olmo said about this PEPFAR platform at the country level, at the lab level, at the clinic level, PEPFAR supports over 50% of healthcare workers in Zimbabwe, and those are community health workers. And these are the same healthcare workers that have been used for the COVID-19 response in Zimbabwe. Really stellar work, and look forward to seeing these are actual pieces that also come out of the community-led monitoring, where the human resources and the attrition at the clinics are, part and parcel in being able to receive HIV services. Next slide, please. And then I wanted to just talk a little bit about a very different model here in programs for sustaining HIV impact and public health response. In Vietnam, we see a very adaptive and evolving model where PEPFAR with the government of Vietnam are working at this public health response cluster detection aspect. They're setting up a comprehensive alert system using case surveillance in 15 high burden provinces. Next slide, please. And looking at cascades like these to say, do we see differences in not only HIV testing, do we see differences in proportion of recency, and then bringing key interventions where they're seeing changes and based on demand overall in different PrEP configurations, looking at outreach to migrant areas and industrial zones, taking a more blended approach through partner notification services and social networking. And this is from feedback through community to really talk about how do we get into these different populations that are not wanting to be identified, but clearly have a need for HIV services. The delivery of self-tests and really like bundling all of these into each of these different clusters that are driven based on the data at each level. And you can see here, coming out of COVID, each COVID wave, there are particular pieces that they address. Next slide, please. And then I won't go through this, but this has their framework and where they're integrating, actually it's probably the next slide, where they're integrating here community and facility along with government and really taking, I think, that community-led monitoring to the next level. And I think this may be my last slide.
Next slide, please. Great. Thank you so much, Iram. Thank you for sharing on behalf of the various countries that PEPFAR supports, examples from around the world, from all the regions, really just showcasing what a tremendous public health asset that PEPFAR and the HIV work really is. It's extraordinary to see this in its entirety. So thank you for that. I'd like to shift now and number one, first just thank the US government implementing agencies. We are stronger together, and it is really profound and amazing what is possible when the whole of the US government comes together. There's no other model like this than the PEPFAR model that really, and I would say, is one of the greatest powers and unique strengths of PEPFAR that brings together the whole of the government, the US government, bringing to bear the various strengths, expertise, and real just passion and compassion for the work that we do. I really want to personally thank each of the agencies in every country, led by our chiefs of mission, but every single one of the agencies that are there, our country teams, and at headquarters, led by our deputy principals that will offer a few words here. It's really just extraordinary. We're all in this together, and we're better because we're in this together. So in this order, I'd like to invite each of our PEPFAR deputy principals from headquarters who lead these agencies to say a few words. First, we'll hear briefly from Clint Kavanaugh from USAID's Office of HIV. Then we'll hear from Hank Tomlinson, who leads CDC's Division of Global HIV and TB. Then we'll hear from Dr. Brad Hale from the Department of Defense, and then Keiichi Achebe from Peace Corps, Carla Haddad from HRSA, and then finally we'll hear from Jin from the Department of HHS Office of Global Affairs. So Clint, over to you.
Thanks, Anjali, and good morning, good afternoon, and good evening, everyone. Like Anjali said, most acutely, I want to thank everyone who has contributed to the support of our PEPFAR Ukraine team and program. In particular, I want to recognize the tremendous effort to ensure that ARVs get into the country and the neighboring region, with these ARV supplies reaching patients in record time. It's been phenomenal. It's also been an example, as Anjali said, of the role that PEPFAR has played, and an example of the emergency response role in particular that PEPFAR has played on so many fronts, including programming within regions affected by civil unrest, drought, and political turmoil. It's a testament of the dedication of our teams to still honor and take seriously the E in PEPFAR nearly 20 years into the initiative. Beyond ensuring continuity of services to PLHIV, our global PEPFAR teams have gone above and beyond to ensure that our collective PEPFAR USG teams, partners, and service delivery partners are supported during these challenging times. And this has been so apparent on so many fronts across the globe throughout the pandemic. Your continued mobilization to support one another on so many fronts has really been awe-inspiring. And despite the well-known challenges across the globe, as Aram noted, we have so many examples of our programs continuing to innovate and evolve in order to achieve and sustain epidemic control. We're seeing programming shifts from models where community and facility were artificially separated to integrated and targeted, with tremendous examples in Zimbabwe, Malawi, and Zambia, where DREAMS, KP, PrEP, and Finding Man efforts are coordinated with our lab and tailored commodity service delivery interventions to support differentiated models that find and retain populations in care. We're seeing last mile analytics and triangulation of data to ensure a laser focus on finding and responding to flare-ups in coordination with our host country counterparts and CSO partners. We continue to see, as you just saw, examples of MMD scaling with correlates of high rates of viral suppression across a number of countries. And on that front, it was really exciting to see at the tail end of last week, our regional program in Asia close out the week with incredible examples of progress in case finding strategies and achievement of viral load suppression across a number of settings. And then in Western Hemisphere, examples of leveraging private sector solutions to support service delivery to KPs. As we are coming out of these VPNs, there with a number of models that clearly will inform the next phase of PEPFAR and clear momentum toward achieving epidemic control. It's something that I think all of us collectively in this call did not think we would achieve in this timeframe. So really just want to thank you all for the tremendous effort of the last few weeks. Looking forward to seeing you at the approval meetings in a few weeks. And lastly, just want to really thank Anjali Ashrakar for her stewardship over the last 2 years of the program. It has obviously been a challenging time, but really want to thank the work of Anjali to keep the program going. So well done, everyone, and look forward to seeing you in a few weeks. Over.
Thanks so much, Clint. Really appreciate that and really recognize your efforts, USAID's efforts, and that of your entire team. Hank, over to you.
Thanks, Anjali, and thanks everybody who preceded me today for your remarks. This is really quite a compelling story when taken in total. We've got 5 more people and 8 minutes, so I'll be uncharacteristically brief, but I really just want to start by saying thank you for your work over the last 4 weeks. We had 3 weeks of big meetings with 7 or 10 or so operating units going during those weeks. Zambia went a little bit before you, and we have a couple of countries and programs who are continuing to meet this week. You all have been fantastic, and I want to acknowledge the contributions and the very hard work of our country teams, our host country governments, our civil society colleagues, multilateral colleagues from all around the world, and most importantly, members of affected communities who may have shown up as part of civil society, but also sometimes independently. These 3 or 4 weeks are incredibly intense. They are incredibly important. And the process that we undergo during this time is unmatched by any other part or program in the US government or any other donor. And it makes us better, but it also doesn't occur independent of other sort of scrutiny, evaluation, continuous quality improvement throughout the course of the year. So thanks for what you've done over the last 3 or 4 weeks, but thanks also for your regular engagement and your regular contributions to helping to identify challenges, to identifying and implementing opportunities, to taking what works and doing it in as many places as quickly as you can. Over the last 19 years, collectively, we have achieved something that few imagined was possible in the time frame that it has occurred. And so the reductions in HIV incidence and HIV mortality that PEPFAR, host country governments, and other partners and collaborators have worked together to achieve is inspiring. And to have done so in the last 2 years, especially during the convergence of 3 pandemics, HIV, tuberculosis, and COVID-19, is even more remarkable. We know it hasn't been easy, but we know that you all have put in everything that you have, and for that I am deeply thankful. I also want to note that, we're at about a dozen or so countries now whose HIV epidemics are not expanding. So incidence is lower than all-cause mortality among people living with HIV. In those places or in the countries close to that inflection point, it doesn't mean that our job is done. In this process and in our work every day, we use epidemiologic and other information and signals and data to plan programs for maximum impact. In doing so, because we understand that risk for HIV acquisition and HIV associated mortality are not evenly distributed, that they affect the most vulnerable members of our societies. We are, and the programs that you implement are health equity in action. There is more to be done though, and so even though at an aggregate level, epidemics may not be expanding, there are gaps that you all have planned to address and are working very hard to, and we affirm your commitment on pediatrics, key populations, adolescent girls and young women and their partners, reduction of stigma and discrimination. Thank you for that work. It is incredibly important and will be a continued focus, even as these overall numbers look pretty good in a number of places. Finally, for the sustaining HIV impact countries, your task this planning cycle has been a little bit different. We appreciate the innovation and thinking that you've done about how to maintain impact, not necessarily maintain the programs that got you here, understanding that what got us here might not be what keeps us here, and your ability to think, evolve, and plan in a way with host country governments and other actors has been admirable. This doesn't happen alone. It's a team affair. We at headquarters at CDC remain available to support our country teams. We do hope to be traveling more frequently. That will, of course, depend on COVID epidemiology, but we appreciate your work. We thank you for our partnership. We look forward to continued impact and are just so impressed by what you all have put in each and every day. Thanks so much.
Thank you very much, CDC. Really appreciate everything that you do every single day. Brad, over to you.
Thanks very much, Anjali, and I appreciate the opportunity to talk to this impressive group that's collectively, between our government partners, international partners, interagency team. First, I just would like to acknowledge that for me, it's been really impressive to see such a collective effort of excellence and determination between all of these groups to come together to fight this pandemic. I'd like to acknowledge our government partners in the Ministries of Defense and Ministries of Health, our interagency team partners in CDC, USAID, HHS, Peace Corps, and HRSA. I really do appreciate our work together. I'd also like to acknowledge our community partners who have really provided some really phenomenal input and guidance as we work through this difficult process of the HIV pandemic control. And also, I'd like to really acknowledge the leadership of OGAC in this difficult time. I've been very impressed by the resilience of this group team. And finally, just a comment about our colleagues in Ukraine who are fighting for their freedom and their lives. I think, they're on our minds every day. I just would like to reiterate our commitment to finding a sustainable data-driven approach to epidemic control using innovative strategies to find our individuals with HIV, provide them access to care, and provide sustained HIV control, virologic control, and a commitment to results-driven programming, and also just a determination to finish this fight that we started. And finally, I just really would like to appreciate everyone's really hard work over these last weeks, and it was a privilege to be a part of it. Thank you very much.
Thanks so much, Brad, and thanks to the whole DoD. Keishi, over to you.
Thank you, Anjali. I want to take this time to recognize all of the hard work being done by all interagency teams, especially our Peace Corps staff in the field. Not only have our staff been working on COP, but like Iram just showed, we have been bringing innovation to our work to ensure effective impact and results. You also have been planning and implementing activities to address the COVID-19 pandemic, and our Peace Corps team have been preparing for volunteers to return, which has been no easy task. Thank you for all of your dedication to serving the communities during this very busy and difficult time. Peace Corps is excited to continue being a dedicated partner in maintaining HIV epidemic control and sustaining impact. We will continue to implement through staff-led and virtual programming, and are eager for the return of Peace Corps volunteers to the field this year to continue the work that our staff have been doing over the past 2 years. Yes, you did hear me correctly. I did say volunteers have begun returning to the field, with the first group that headed back to Zambia earlier this month. We do expect most posts should have a small group of volunteers by the beginning of this COP. I would also like to close by acknowledging our colleagues and friends in the Ukraine. We hope that you and your families continue to stay safe and well during this trying periods. And last but not the least, a big thanks to someone I like to call my sister and friend, Anjali. She is a leader indeed. She fights tirelessly for this program. Thank you, Anjali, and to all the team at OGAC. Thank you.
Thank you very much, Kechi, and thank you for your leadership at Peace Corps and all that Peace Corps brings. Finally, and quickly, hopefully, we'll hear from HRSA and then HHS Office of Global Affairs. Carla, over to you.
Thanks so much. Good morning, good afternoon, good evening to all. I'm delighted to say just a few words on behalf of HRSA to recognize the entire team as we conclude another very intense planning season for 2022. So first, I just want to commend all of the implementing agencies for your remarkable resilience during this unprecedented time of change. I know change is both hard and constant throughout all of our organizations, especially when working in global health. And on top of this, we've had shifts that have occurred due to the COVID-19 pandemic, as well as very difficult conditions on the ground affecting provision of services, especially in Ukraine. And throughout all of this, I am just incredibly proud of how hard the HRSA team in particular has worked with all partners and stakeholders to ensure that the critical training and services provided can continue even amidst these changing times. So as HRSA continues to work toward our mission, we want to reaffirm our commitment to increasing access to high quality services and care for people living with HIV and other underserved populations globally. And we look forward to all the ways that we can continue to support this critical life-saving work in collaboration with our key partners here. To the HRSA team, thank you again so much for all you have done already and all you are to do. And never forget that every contribution makes a difference. And of course, huge thanks to you, Anjali, for your outstanding leadership during this time. Thanks.
Thanks very much, Carla, and thanks to the entire HRSA team. Jen, over to you.
Great. On behalf of the Office of Global Affairs at the Department of Health and Human Services, I'd like to also add my appreciation and thanks to the government, civil society, and USG colleagues, both in country and headquarters, for the engagement during the COP22 process. I think that just reflecting on Nirum's presentation, the progress of the program speaks to everyone's adaptability, resiliency, and dedication to the people that we serve. I'd like to take this moment to thank the staff at SDAC, the chairs of PPMs, and many others that work behind the scenes to make this all possible. And I'd especially like to thank you, Anjali, for your steadfast leadership throughout this process. Again, having going through this for 2 years in this dual pandemic, this just speaks to your leadership over the time. I just, as a last speaker, I'd just like to thank the dedication and service to everyone. And I hope to see everyone in the near future. Back to you.
Thank you so much, Jen. And I know we're just over time, but let me close with a few thanks of my own. First, I'd like to really note that while the COP and ROP 22 planning meetings are over, well, almost, we've got one more. The journey together continues. Over the next several weeks, these ROPs and COPs that were jointly planned will be submitted, reviewed, and approved, and be ready for implementation come October. But over the year, as Hank noted, it's not just a planning meeting. that ends. We will continue to work together in partnership, to implement together, to monitor together, to be resilient together in the face of whatever crisis comes our way. We are better together. And as Dr. Omo said earlier, we can believe in and do bold things, and it's possible, and we've seen what's possible with PEPFAR. So I'd like to close with some thanks. Thank you to our chiefs of mission that lead our missions across the globe. Thank you to the entire SGAC team. It is a tireless effort. You all from every corner of this office have contributed so much. To our chairs and our program managers and our liaisons, thank you. To our PEPFAR coordinators in country, doing everything that you do every single day, thank you. To our agency headquarters, we heard from our deputy principals, but all leaders at our agencies and all staff at our agencies, from headquarters to the casts, to the country teams, to our partner governments from across all the sectors. You are the leaders, and we are privileged to work side by side and together with you. Our multilateral partners, Global Fund, UNAIDS, the WHO, and others. Civil society in all forms, local and global, and all of our implementing partners. Thank you. Thank you, everyone, for everything that you do. Please stay well. Please stay safe. We'll be in touch very, very soon. This concludes our meeting. Take care, everybody.
Bye-bye.